full disclosure, I don't have slides. I sat next to Elizabeth. Elizabeth, where are you? There you go. And she said, speak from your heart. You don't need your notes, and you don't need any slides. So here's what my mom said to me one day. She said, Debbie, ask him what he's saying. I don't understand what he's saying. So I said, what are you saying? Tell her the baby in her belly is dead and she's going to need an operation. And just tell her to sign here. I was 10 years old. I sat in the back of the car and cried all the way home. I dreaded going to the doctor with my mom. Because even though she spoke English relatively well, she preferred to listen to healthcare information in her primary language of Spanish. So today, I'm going to share with you why it's important to remember that limited English proficiency is something that can be a barrier in health and healthcare. And in fact, the most vulnerable populations are right around you in your own community. Let me share another story. Willie Ramirez in 1980 showed up to a South Florida emergency room. He was comatose. He had developed a severe headache, had gone to his girlfriend's house. They called 911. And the clinicians in the emergency room evaluated him. No focal neurologic signs, just pinpoint pupils. The Cuban family used the word intoxicado. They kept telling the clinicians, intoxicado. The clinicians admitted him to the ICU for a drug overdose, interpreting the word to mean intoxicated. 2 days later, they discovered that Willie hadn't overdosed at all. Intoxicado to Cuban families means nauseous, not feeling well. He had a brain hemorrhage. $71 million later, a legal lawsuit was settled. Willie is now quadriplegic. Those clinicians, family members, and Willie will live with that decision. So, when we think about limited English proficiency and the profound impact that can have when you access health and healthcare, think about that. You see, culturally, sometimes we experience barriers too. The family didn't want to challenge the doctor because in Cuban families, that's a position of authority. So even though they couldn't believe that Willie would take a drug overdose, they failed to challenge the physicians and the clinicians because culturally, that's just not what they do. So let me define limited English proficiency as the U.S. Department of Health and Human Services defines it, which is no fluency in the English language and unable to communicate effectively in the English language. The U.S. Census Bureau defines LEP as not speaking English very well. What's the scope of that problem? Well, in 2011, 9% of the U.S. population doesn't speak English very well. And over the past 20 years, that's grown by 81%. The 3 states with the largest populations of LEP, California, Texas, and New Jersey. In New Jersey, in fact, foreign-born persons moving here have been the largest population growth that you've experienced. 42.6% of New Jerseyans don't speak English very well, and 30% of them speak a language other than English at home. These individuals bring a unique culture, language, history, health attitudes, and beliefs to your healthcare organizations and to your community organizations. So how does that differ when you're taking care of a patient that doesn't speak English very well? Well, sometimes we may have biases, some we're aware of and some we're not aware of, otherwise known as unconscious bias, particularly in patients with heavy accents. For example, research has shown that our brains, when we hear a heavy accent, may identify that person as someone that's not within our group, much like you would use skin color or clothing as identifying a non-native. So unconscious biases can be formed when you encounter people that are not from your own group. In fact, research has shown that our brains take a little bit more time. It's harder to understand non-native speech than it is to understand native speech. And conversely, research has shown that our brains pay more attention to native speech than it does to non-native speech. A speaker's accent may make it harder for listeners to understand what a person is saying. This judgment has tremendous implications in healthcare. Because a person's intellectual ability is often based on how well he or she speaks English, Title VI of the Civil Rights Act in 1964 says that you cannot discriminate against national origin, which includes language. So how can we address this as a community? Well, best way is to use a medical interpreter. In our organization, we have 8 full-time trained interpreter and 140 employees that we've trained to interpret while they're doing their job. It's important to note that medical interpreters are not just bilingual individuals. They have competency in a language other than English, but they have also social and cultural competency so that they can interpret in the other language so that the patient can understand what's being said by the clinician. In order to be effective communicators, don't just try to get by. Sometimes people think, oh, I can speak a little bit of that. But actually, sometimes that's worse. Carefully consider getting a video conference, a blue phone, someone that can speak that language, and not try it yourselves. In our organization, we tell clinicians that they can actually choose an interpreter even when a patient has a family member by their side that can speak that language. Why? To avoid what I just described. A few tips that may be helpful for you. When you're working with someone that doesn't speak English very well, provide the interpreter with some background on what you're going to say to the patient that day. Ensure to address the patient and not the interpreter. Remember that everything that you say in the room will be interpreted, such as things you say under your breath. Avoid using idioms like it's raining cats and dogs. It may not mean the same thing in the other language. And of course, don't ask interpreters to do something that's not the task of interpreting. At all times, avoid using family members or children. And when caring for patients with heavy accents, don't speak louder or ask them to speak louder. They're not deaf. Just speak slowly and ask them to speak slowly. Let me conclude with one other story. There's a young man who's a physician and a faculty member in our organization. And he relayed a story about one of our own patients that I'd like to share with you. Rounding in our hospital on a weekend can be difficult. And so he got sign out from another clinician. And the job was go in and see the patients, get sign out both on a sheet as well as verbally from the clinicians that have been taking care of the patient the day before. So his objective was to see all of his patients. And he was signed out, young Korean, an elderly Korean patient who they were having difficulty with. They couldn't figure out what was wrong with her. She wasn't responding. And in fact, her son, who worked long, long hours, had been not in the hospital recently. And so he was told she's Korean. That day, Dr. Gertner used a blue-headed phone and said, let's try this again. I've been told by the sign-out team that she's not responding to the Korean interpreter on the phone, but let's try it again. So he dialed the Korean interpreter, And the interpreter said hello, and the patient didn't say anything. So Dr. Gertner almost walked away when he heard the interpreter say, "Sir, sir?" He said, "Yes." He said, "Are you sure you want a Korean interpreter?" He said, "Why do you ask? Her last name is Burmese. You may want a Korean interpreter." And so he hung up, dialed again, asked for the Korean interpreter, and the patient started to respond. It's interesting that when we listen and we pay attention to our patients, we can improve their quality of care. We know that we can reduce medical errors. We know that we can improve compliance with medications and follow-up appointments. We know that we can make a difference. Thank you.